I'm Jean-Michel Arnaille. I'm an ICU physician working in Toulon, France. And we will discuss a clinical case using advanced monitoring with Vivo 45. The case is Mrs. Kirsten. She is 60 years old. She has a Steiner myotonic dystrophy, diagnosed a long time ago. She's using NIV at home for the last 10 years with a nasal mask. She was hospitalized in an ICU in 2016 for an acute exacerbation. She has a surgery for cataract in 2021, and she was addressed to our long-term NIV unit in 2022. At the first visit, she complained about morning fatigue and morning headaches. The arterial blood gas at the visit was normal during the day, 44 millimeters of mercury. The ventilator setting was an EPAP of 4, an IPAP of 21 centimeters of water with a backup rate of 12 breaths per minute. She used NIV 8.5 hours every night in a regular way. There was no intentional leak, and the apnea-hypopnea index was 7 events per hour, according to the ventilator. So at that time, we performed a first transcutaneous capnography on NIV, and the exam showed that the first value in the evening was around 44 millimeters of mercury, and she ended the night at 53 millimeters of mercury, with the maximum value along the night around 60 millimeters of mercury. And so the mean transcutaneous CO2 was 51 millimeters of mercury, with, as you can see, some desaturation when there was a rise in the CO2. So we consider it as a persistent hypoventilation during the night, and we decided to increase the backup rate from 12 to 15 breaths per minute. Then she came for a second visit a couple of weeks later. She was still complaining of morning fatigue. The PaCO2 during the day was normal. Now the ventilator setting was still EPAP of 4, IPAP of 21, and a backup rate of 14 breaths per minute. The daily use was 9 hours in a regular way. There was no unintentional leak and a few obstructive events. So we performed a second transcutaneous capnography, which was considered better as the previous one, with an initial value of the corrected CO2 at 53, an ending value around 42, and a mean transcutaneous value of 45 millimeters of mercury. So we consider that the hypoventilation was corrected, but we were a little bit surprised by such high value in the evening. So we suggested the patient to use an IV during the day, for example, during the nap. Then the third visit, 6 months later, the patient still complained of morning fatigue. The PaCO2 was normal, 45 millimeters of mercury. The ventilator settings were unchanged with an EPAP of 4, an IPAP of 21, and a backup rate of 14 breaths per minute. The daily use was 9 hours and 15 minutes regular. And we noticed some cluster of unintentional leaks with more obstructive events than before. So this is an overnight recording of the data, where you can see the spontaneous breath. So the patient was mainly in mandatory breath during the night. This is pressure, flow in blue, and total leaks in purple. And as you can see, there was some cluster of unintentional leaks with a suspicion of changes in the flow. So if we zoom in, this is what we found, that there was some regular decrease in the patient flow, with increase in the total leaks. Now, if we look a little bit in detail, there are two hypotheses here. It could be a passive opening of the mouth that created the leak with a decrease in the patient flow, or the other way around, an obstruction of the upper airway with, as a consequence, an opening of the mouth. So to characterize this event, we perform a nocturnal oximetry, which showed that there was a symmetric desaturation and resaturation, meaning that there was the repeated desaturation with the speed of decrease and the speed of increase was the same, which indirectly suggests a central event. But to characterize, we need a polygraphy. So we used the belt that you can connect to the Vivo 45. And in the same time, we connected the Centec capnograph to the 45. So we were able to do a polygraphy with spontaneous breath, pressure, flow, total leaks, effort belt. In blue is the abdominal belt, and in purple, the thoracic belt, and the raw measurement of the PTCO2. This is a transcutaneous capnography for the same night on the Centec device that shows that the starting value was around 35 millimeter of mercury. The ending value was also around 35 with a mean value of 38. But as you can see, there was some large change in PTCO2 during the night. And you can see that the corrected line, corrected according to the drift, was very close to the raw value, meaning that the raw value recorded by the Vivo 45 was almost equal to the corrected one. And now if we zoom in, you can see something a little bit particular, that there was some desaturation, but if you are very careful, the desaturation occurred during the rise of the CO2 and not during the high level of CO2, as we could explain if it was an alveolar hypoventilation. So now we are on the BRIAF software where we can see the settings of the patient and the detailed recording of the 3 last sessions, where we can see that the spontaneous breath was very low, meaning that the patient was mainly on mandatory breath. The mean tidal volume was a little bit less than 500. The total leakage was a little low, meaning that there is no unintentional leaks. And the apnea-hypopnea index was quite high, with on average 19 events per hour. Now I will zoom in the last session. And display the main parameters, the spontaneous breath, the pressure, flow, total leaks, effort belt, and the transcutaneous CO2. So I prepared already the optimal range for the y-axis. And here again, you can see that there was big changes in the CO2 during the night. So now let's use a time scale of 1 hour. And we will start by the beginning of the night. So if we look in parallel at the transcutaneous CO2 and the effort belt, I can probably increase the effort belt. And the flow, the patient flow, you can see that when the patient started an IV, the transcutaneous CO2 decreased from around 45 to around 35. And then when it reached 35, there was some events here. We will zoom in to see if they are central or obstructive. And you see that these events are associated with an increase in the CO2. And then when CO2 increases, there is no events anymore, but CO2 decrease again. And the same occurs as soon as CO2 goes down. There are some events occurring that increase the CO2. And again, each time the CO2 decrease, there are some events. We can see again here, events with an increase in the CO2. Here again, in the morning, and again. So it seems that these events are protecting against hypocapnia or severe hypocapnia, and they are occurring at a threshold of around 35 millimeters of mercury. Now, let's zoom a little bit on one of these events to see with the effort belt how they are. So if we use a time scale of 20 minutes, you can see that there is some obstruction, partial obstruction, with no effort from the patient. Let's move to another one. The same occurs here, here, here again, and here. Let's zoom in with a time scale of 5 minutes. And you see, obviously, that during these events, there is no inspiratory effort. Now, we can see the same event as what occurred in the previous recording, with a decrease in the patient flow, an increase in the leaks, and no effort. So it means that these events are upper airway obstruction associated with no effort, meaning a central mechanism due to hyperventilation and hypocapnia. And it seems that these central events are protecting the patient against severe hypocapnia, because at each time there is an event, there is an increase in the CO2. So the interpretation of this recording was that the obstructive events were due to a decrease of the respiratory drive, and the decrease of the respiratory drive was associated with hypocapnia, which means that the patient was hyperventilated. So we decide to decrease ventilation by decreasing IPAP from 21 to 20 centimeters of water and decreasing the backup respiratory rate from 14 to 12 breaths per minute. And then we had the fourth visit 3 months later. The patient did not have morning fatigue anymore, and she was more active during the day. The arterial blood gas was still normal. The ventilator setting was EPAP 4, IPAP 20, backup rate 12. The daily use was 9 hours and 10 minutes regular. There was no intentional leaks and a much less obstructive event. So this is the second recording with the modified settings that showed that the transcutaneous CO2 was more stable than before with less variations, and there was less event than before. Now, if we look at the detail of the transcutaneous capnography, the starting value was around 37 millimeter of mercury. The ending value was 39, and the mean was still 38 millimeter of mercury. If we look in the detail at the polygraphy, there were much less events, still a few decrease in respiratory drive. So to conclude, obstructive events are common in neuromuscular patients. The effort belt help to characterize the mechanism of the obstruction, and it's very frequently a decrease in the respiratory drive in neuromuscular patients. Combining transcutaneous capnography and the effort belt help to assess a transient hyperventilation. So I consider it as an advanced monitoring that is useful to optimize ventilator settings in order to improve the quality of ventilation and sleep. Thank you for your attention.